Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about hypertension. As I mentioned last week, hypertension is a very common medical problem. Worldwide, 1.5 billion people have hypertension, and every year, 7.5 million people die because of hypertension in the world. In this country, you have 76 million people with essential hypertension, and altogether you have 67 million folks with so-called prehypertension, which has to be talked about in context. So it's very common, and every year it is said some 46,000 deaths could be avoided in this country if hypertension was treated properly. Okay, now before I get into the details, I want to once more share with you this book that I wrote. That's now about maybe about 4 months now since it came out. The title of the book is The Art and Practice of Modern Clinical Medicine. It has 136 chapters, 889 pages. I wrote it all by myself. It is a great book that covers clinical medicine, not only in this country, but throughout the world as it relates to the 21st century. If it is truly and honestly high-powered academic medicine that you're really interested in learning or using to treat patients, you should get your hand on this book. I am not in the public relation business. I'm an academic doctor, and I don't have the staff, whatever, to push book all over the world. But certainly you can find it, I'm sure, in the local public libraries. You could also find it online, as well as there are always some copies in my office. Now let's get back to hypertension. What I mean to do in this segment is to try to explain to you some of the medication that are in use to treat hypertension. As I mentioned last week, the basis for essential hypertension is salt retention. The gene has been identified, G protein receptor kinase type 4, something that I hypothesized many years ago, and people took it and ran with it, did the research, and in fact discovered this gene in the kidneys of all human beings in the same quality, the same quantity. Hence, the reason for essential hypertension. And what it does, in fact, is called salt retention. You can't treat blood pressure properly. No way can you treat blood pressure effectively in anyone, except, of course, individuals who have end-stage renal disease, the kidneys have already failed, then without, of course, using a water pill. What the water pill does is that it gets rid of the salt, and wherever the salt goes, the water follows the person urinate several times during the course of the day, and then that facilitates the lowering of the blood pressure. Now I want to go over with you how some of this medication work. Here I have hydrochlorothiazide. That's a diuretic. When you use that, it helps to mobilize salt within the body, and then the salt allow water to follow it, and the water goes out in the urine, and the person intravascular system senses that the water is coming out, and of course the pressure goes out that way. I have hydrochlorothiazide, I have chlorothalidone, I have diazide, modiuretic, aldactone, lozol, maxide. Those are really the so-called thiazide diuretics. I have three other diuretics on this list, which are Lasix, Bumex, and Torsemide. These are loop diuretics that works in a different part of the kidney to allow salt and water to come out of the body, and they work pretty quickly within half hour after somebody is given it either by mouth or intravenously. But they work so quickly, they're very good to treat congestive heart failure, but they're not good enough to treat hypertension. The reason is that the medication that we use for hypertension lasts anywhere from 8 to 12 hours. They slowly get the salt and the water out. Now, if somebody happens to have congestive heart failure, of course, we're giving them several medications, and they also happen to be hypertensive at the same time, we're clearly going to give them loop diuretics plus a whole lot of other medication to treat the blood pressure as well as the congestive heart failure. Because you can't use a diuretic, a thiazide diuretic and a loop diuretic at the same time. It just doesn't make any sense. Okay, so these are the medication and use to treat blood pressure. And that happens to be the first medications that one must use in the treatment of blood pressure if the person has a functioning kidney, namely he or she is able to urinate. That's it. That's the bottom line. You have to understand that the kidney is really the center of the causation of blood pressure, as well as the kidney is the center of the treatment of blood pressure, because we're using a kidney to treat blood pressure. At the same time, we know that it is the kidney that's responsible for the blood pressure. Okay, now that you understand that, there is no question about it. There are other medications which I'll be getting into in a little bit that can be used as a second medication or the third medication, depending on how high the blood pressure really is. Okay, now first you must try that. It's a step ladder fashion. Okay, you try the diuretic. Sometimes we must start the diuretic and another medication at the same time right away because the patient shows up for the first time. The blood pressure is very, very high. Now, before I even continue, I want to let you understand that blood pressure blood pressure is categorized from the so-called prehypertension, stage 1, stage 2, stage 3, and stage 4. Okay? If somebody has blood pressure, let's say, of 130 over 88, we call that prehypertension. If somebody, let's say, have blood pressure 140 over 89, that's stage 1, and so on and so forth. This is all listed in this book here in chapter 1. And also, there is a point where it was so-called hypertensive crisis, when somebody's blood pressure is definitely all the way beyond stage 4, where they show up in the emergency room blood pressure of 230 over 160. That's a crisis, because the patient is about to bleed into the brain if you don't step right in and use different technique that's going to quickly lower the blood pressure in an emergent way. And I'll tell you how we do these things. Again, I'm going to take my time to do this very slowly, very carefully, for a multitude of reasons. First of all, many, many doctors and PAs and nurse practitioners and medical students listen to this show. I know because they see me in the hallway and tap me on the shoulder. I can tell you it's a sense of great pride that I've been doing this show for 24 years now. November will be 24 years. Not a single time have I ever received a phone call or email or a verbal communication that, Val, you said something in your show that was not correct. Can you imagine that? 24 years I've been doing the show. Not a single time anyone in the healthcare profession ever, either a student, a physician, nurse practitioner. In those days when I started, the concept of nurse practitioner didn't exist, but I believe PA may have existed then. And so not even once, either in this country or anywhere. So that's a sense of great pride. So I'm taking my time to explain this thing to you very carefully. What I have gotten comment on by my colleagues is, my God, I don't even have to do those courses, the CME thing. All I have to do is just listen to your show, and I'm learning medicine all over again. Okay, so that's why I take my time and do this show, because I know that I'm making a contribution not only to the public, individuals who are not in the medical field, but who are recipients of medical care, which is the reason I'm doing this, really. I have no other alternate, I have no ulterior motive whatsoever to doing this show. I do it as a payback to this extraordinary country that has done so much for me, to allow somebody like myself, who had such a horrible start in life, to open the door for me so that I can get to where I am. Multiple offers, as you can well imagine, have been made to me over the years to commercialize this show. The answer has been no. Multiple offers have been made for me to commercialize the books and stuff that I've written. The answer is no. I have no interest in that, not whatsoever. I guess that's the reason why the show has such credibility, because it's not commercialized. Nobody can tell me what to say, when to say it, what to do, and how to do it. Okay, you understand that? So now that we talk about the different stages of blood pressure, we talk about the thiazide diuretics and so on. There's another a group of medication that I have to bring to your attention. Of course, this is the ACE inhibitors. Let me talk about the ACE inhibitors first, I think. Basically, they're here, so I don't think I copied the sheet, but I can talk from the top of my head. First of all, I want you to understand these are very good medication. The ACE inhibitors are very good medication when used in the proper setting. I have them listed here. I have Zestrel, I have Acupril, I have Carpoten, Vasotex, Monopril, Altace, Myvic. They're very good medication when used in the right patient and the right set of circumstances. Okay? Now, why is it that the ACE inhibitors are not to be used in non-Caucasian individuals? Why? Well, the reason is because all non-Caucasian individuals, no matter the drop of Negroid drop they have in their blood, mean that they have low renin. You can't be a non-Caucasian individual don't have low renin. That's the bottom line. This is how God created folks like me. We have low renin. Asian have low renin. Black folks like me have low renin. Latino folk has low renin. So, well, what is renin? Well, renin is a product that is produced, again, by the kidney. There's a renin-angiotensin-aldosterone system. Keep that in mind, a renin-angiotensin-aldosterone system. That system, that's the system that the kidney produces that really control hypertension. Its elevation, as well as you have to use that, take advantage on to treat it. So all ACE inhibitors, and I've listed them to you: Zestrel, Acupril, Captopril, Vasotex, Monopril, Altace, etc. They're excellent medication, but they're all ACE inhibitor. Their mechanism through which they work to lower the blood pressure, they have to block renin. That's the key. They have to block renin. Well, if you're a non-Caucasian person, now you have to understand that. Let me set it in context so you understand the point that I'm trying to make. There's 7.4 billion people in the world as I speak. 4 billion of folks live in Asia. That's when they're non-Caucasian, okay? 1.2 billion of those folks live in Africa. That's 5.2 billion right there out of the 7.4 billion. And I have not mentioned anything about North America. And don't even get me to go there, because then the entire Americas, okay, are non-Caucasian folks, no matter what they may think of themselves. Do you know that out of Nigeria, the country with the most black folks in the world happens to be Brazil? Did you know that? Did you know that Brazil has more black folks than any place else other than Nigeria and Africa? Now, you can't make this up. This is a true story, okay? All right, so therefore, if I were to go there, now, you understand what the point I'm trying to make? So, Caucasian folks, they're the minority. I have nothing against Caucasian folks. Nothing. I wouldn't be where I am without help that I received from Caucasian folks. My grandfather was a Caucasian. My great-grandmother was a Caucasian. My mother is half white, half Caucasian, whatever you want to call it. And as I stated before many, many times, not a single thing of major importance that happened to me as I was struggling as a young man to get ahead without the extension of a hand of a Caucasian person who realized that I had intellectual talent and put the arm around me, say, Val, we're going to help you. We're going to help you to get ahead. We're going to open doors for you. And they did. And I'm grateful for that. So I'm giving back. So now that I've made my point, so you have to understand that the Caucasian way of teaching medicine, I'm part of that. I don't do it. I teach my students, my intern and resident differently. But that's not what's going on in the country. So therefore, of all the diseases that we have to deal with, the single disease that is less well understood and treated less well happen to be hypertension. And the saddest thing of it is that this is the one disease that is in fact controlled by a committee of experts that issue report every several years. And yet, folks don't listen. Okay? They don't listen. And that is the reason why there's a change now that's taken place by the AMA, giving, I think, 33 schools now have taken the several $1 million grants to change the way they teach intern and resident medicine. Yet this week, I just went on the AMA, must have been today is Thursday, I went on the AMA, must have been a couple of days ago, website. Residents from major training programs are saying the same thing. They're not satisfied with the way they're being taught, and they are hoping and praying for change so that they can go out there and practice medicine different than the way they're being taught. In the book, this is resident. They're talking. I left residency many years ago, 1978, when I finished my fellowship. And these folks now, they're experiencing it. And they're realizing that the way they're being taught is not the right way. Because when they go out there, they know that you have to be ethnically sensitive towards your patient, and you have to have ethnic and cultural understanding of the patient in order to treat them properly. Because if you don't, you're going to miss a slew of diagnoses. Guaranteed. No question about it. Just last week, got involved in a patient care for the first time, who's been in major medical centers, just discharged from them. And I agree to help out. You won't imagine the stuff that I just last week, H. pylori. And how did I come up with examining somebody, diagnosing H. pylori on someone who just left a big medical center? Well, I happen to know the culture of the individual. I know where that individual comes from. And I know right away he or the individual is likely to be infested by H. pylori, which is a very bad thing. That's all. There's no other reason why I did it, and it came back positive. I also turns out to check the individual hemoglobin electrophoresis. Why? Because it's a black person, and I know I need to check to see the abnormality that I'm looking in his blood wouldn't be associated with abnormal hemoglobin, because this is this Negroid person. And sure enough, you won't believe this. Just last week, the test come back, the individual is carrying hemoglobin C. I mean, you can't make this up. This is someone who just got discharged from a major medical center, when in fact his life was saved because for what he went there for. But all these other stuff that are extremely relevant to his symptoms, to other symptoms that he's having, were completely never thought of. Never thought of. As a matter of fact, there was some thrombosis involved. I mean, don't get me started. And supposed to have had a high coagulation workup done. Sure. But guess what? They missed the one that's even causing the problem. Why? He's a black person. And that particular one happened to be more common in black folks. That test was not done. Give me a break. Right there in my little office by myself. 3 major things, just last week. So I'm not criticizing everybody, but I'm just making the point how important it is to understand the culture. You don't have to be a genius, my friend. All you have to do, I know where that person comes from. Therefore, there's certain things that's bothering that individual, I know are likely the result of, because of its ethnicity. That's all. There was no $1 million machine involved. Just this brain here, and now appropriate medication is being given to the individual in question. And I mean, you can't make this up, okay? So in any event, you have got to understand that is why very few folks are getting the blood pressure treated. Many of them don't go for treatment. Can't blame the doctors for that. And for those who do go, small percentage are getting blood pressure being treated properly because they're not getting the proper medication. Because as far as you're concerned, The drug company said this medication is good for blood pressure. I got a prescription for it. I'm in the clear. You're not in the clear. You can't just write prescription. You got to look at the person you're writing the prescription for, right, sitting right in front of you. And you have to have, see, clinical medicine, we don't have time sometimes for results to come back. We have to use judgment. 75% of what doctors do every day is based on judgment. You've got to make the judgment that this individual requires this medication because it is appropriate for him or her, for him or her. Otherwise, forget about it. Okay? So, since black folks are all non-Caucasian folks who don't have end-stage renal disease, who don't have renovascular hypertension, have low renin, why give them an ACE when there are so many other medications out there? They do. I got into a fight earlier last year with a drug company because one of my patients, a black lady, is getting an ACE inhibitor and the blood pressure cannot be controlled. So the fight was, they sent me this list of stuff, medication that this drug company will pay for. Not a single one of them on the list, not a single one of the medication on the list was appropriate for a black or Latino person. And yet this drug company is getting money from these people through their union to provide this medication for them. So I raised holy watch, you understand the point? And I wrote a letter saying that this is ridiculous. I don't have a monopoly to this science. This is the science. Why are you doing this? Something that costs $7 per month is not listed on that formula list that you sent. Give me a break. So I never got a response to my letter. I not good with the computer. Until 1 o'clock in the morning, click, trying to write this letter. Never get a response because they don't want that on their profile. And then about a month later, I happened to pick up the phone and call the pharmacy in Yonkers. I said, whatever happened to that patient of mine? Oh, it was approved, but the patient was never notified. You can't make this up. They never notified the patient. They approved the medication because I raised hell, never notified the poor lady, and the medication was sitting there because they don't want that communication so that legally there'll be a record of that. You can't make this up, okay? And this is, the union is paying for this. It's the same thing. I mean, it is crazy. You can't go, I can't give a prescription to a menstruating female to go to the pharmacy for iron pill. That's not approved. And what is the number one disease in menstruating female in the world? Iron deficiency anemia. And yet they're paying the money to the drug company out of the paycheck, and yet the disease that's the most common. All menstruating female have iron deficiency to one degree or another. So the medication they require the most will be iron replacement. They're not getting it because it's not approved, and it's expensive. It's $40, $45, $60 a month. And rightfully, they don't want to pay for it because it's a lot of money. They're paying the insurance. It's not approved. It's vitamin. You could buy it over the counter. But the good one you can't buy over the counter. It has to be prescribed. In any event, you get the point that I'm trying to make, okay? It is ridiculous what's going on, okay? So now that you cannot use an ACE inhibitor in an individual who are not Caucasian, what then can you use? Well, here we come. Here we go. There's another concept. You need, so since the ACE inhibitor only works to block the renin, and you can't use it because the renin is not high enough, then guess what? There's another medication. They call them M.A.C.P, angiotensin receptor blocker. Okay? That's called an M.A.C.P. Angiotensin receptor blocker covers the entire pathway of the renin angiotensin aldosterone pathway, all of it, from beginning to end. From beginning to end. So you use an M.A.C.P. Use the M.A.C.P. And let me give you an idea of some of the M.A.C.Ps, okay? Cozar, Avapro, Diovan, Asion, Atacon, Benicare, Micardis. These are all M.A.C.P. And there are more out there, I'm sure. They block the entire renin angiotensin aldosterone pathway from beginning to end. Therefore, they block the whole thing. And if you have to add a water pill to them, since the J- JCNH came out with this report years ago, now all of them, all the ones that I've mentioned, except a couple, have a thiazide already attached to them. So you could use some, you could get somebody Cosa with hydrochloric acid. They have that combination now. That's where that comes from, by the way. So you're giving them two medications in one. They take this one pill a day, and that works beautifully. You block the entire pathway. Regardless of your ethnicity, it works. Period. Period. So why not do that rather than giving somebody something that's not working because it's cheaper, and the drug companies that are managing the plant won't pay for the herb because these are cheaper. The fact that they don't work doesn't matter to them. They just, that's all they care about. They put it out there. That's disgusting. It is greed beyond comprehension, and it's happening every single moment of every day in this country. Greed and greed and greed. That's all it is. Greed and greed. I'm a capitalist. No question about it. I want everybody to get ahead. I want everybody to make money, work for it. But don't at the expense of people's health to take their money. It makes no sense. I don't care. I'm a patient advocate. I don't have to make any excuse to anyone. That's who I am. That's what I am. They don't like it. Well, you could do what they want about it. They've tried to do what they could about it. They failed. So I don't have to. I can look at them in the face and say, you don't know what you're talking about. Keep trying. You're wasting your time. So in any event, you could use an herb in conjunction with a thiazide water pill. You'll treat the blood pressure very effectively, okay? Now, when I continue next week, I'll talk about other medications such as the calcium channel blockers. I got to take time to talk about those because this is a big family of medication I have to talk about. Listen, until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.